Hi, I'm Rod Hochman. Welcome to another AHA Leadership Rounds. These have been lively, and what we've been trying to do is get the experience right from the front lines. And as you know, I'm the CEO and president at Providence out west in the western United States. And we've been doing these to really get some sense of what's happening with this pandemic that's now a year and a half old. And I think at this time we were hoping we'd be talking about something else. And for a lot of us on the front lines, what I think we worry about most are our people. How do we keep them going with all that they've been through and the stresses that they've been under? And they truly are, the first responders in this pandemic that we've seen over this year and a half. I'm really, really pleased today to have with me as my guest, Dr. Fritz Francois from NYU Langone in my old hometown of New York. He's a pretty amazing guy, to say the least. Besides being chief medical officer, he's also a professor at the NYU Grossman School of Medicine. And NYU Langone has been an incredible institution in New York for a long time and has really been a leader in dealing with so many different things on the research side of things and in care, located in the heart of Manhattan, and it has six inpatient locations. Dr. Francois has done a lot of things in his career. He is always on the front lines. I mean, he's one of those folks that I would describe as someone that runs towards a fire, not away from a fire. And he led a humanitarian mission in Haiti, which is where he was born, his birthplace, and joined colleagues as they braved 9/11, which we've also remembered just in this last week or so. If that wasn't enough, Hurricane Sandy, as a number of us know, really devastated New York and particularly devastated the medical center at NYU. And then, if that wasn't enough, he led a response to a major fire in a Kimmel pavilion that was under construction. So pretty amazing. And, you make us proud in terms of all the things you do and what you're doing. So it's great to have you with us.
Well, thank you so much, Dr. Hochman. And I got to tell you, the East Coast misses you. But it's a pleasure to join you for this conversation today. Really, much has happened as you've indicated, and I look forward to having this dialogue with you.
Right. So let's kind of look backwards for a moment, and you're used to kind of getting people and your team to dive into a situation and be able to do it. And I think how you prepare your workforce for that. And I think someone told me a little bit that it's about the 5 T's.
Yeah.
Right?
That's right. Yeah, that's right. But, I have to tell you, this is an interesting story as to how we even got to those five T's, if you will, because in their introduction, you made reference to the fact that we survived Sandy, and we were the only medical center that were completely shut down at the time. And then there were these other emergencies that we faced, including the Kimmel fire. And so the reality is that over the years, baked into our DNA, the DNA of the organization, has been this notion of preparedness. And we got to a point where we were doing these sessions almost at least twice a year. We would do these major tabletops to think about how we would respond to certain emergencies. And among them, we've dealt with, imagine a cyber attack, imagine an active shooter, imagine you lose power, etc. And so we are planning on doing these things. And in the fall of 2019, we decided that we were going to do that. Our next tabletop exercise was about an emerging pathogen. In fact, what if there was a deadly virus that struck? How would the medical center deal with it? And we decided that the date for that tabletop exercise, initially we were thinking about November, either November or early December of 2019, believe it or not. But we decided that we were going to have it on January 8th, 2020. And as you recall, we first learned about some of the cases from Wuhan on late December 31st, in fact. And so by the time we were having this tabletop, you can imagine, like, we do it with all the leadership and all the key individuals in the organization, key leaders, and you sit around the table and you go through this, and we had the scenario that we just learned of this outbreak that has impacted the medical center. And what do we need to do? How do we need to prepare? What are the things such as tools, teams, therapies, triage, throughput? Those are the 5 T's, by the way. What are the things that we need to do? And all this is going on before, I would say, 99% of those in that room heard anything about Wuhan. Now, the chief of the hospital and I actually had heard about the cases, and we mentioned it just literally one line before we started. I said, heard about these couple of cases actually, and these cases in Wuhan, just in passing. Yeah. And of course, within days, we now knew more about what was going on. And it was within a couple of weeks we officially activated our emergency preparedness center, actually, to now really prepare, not for this scenario, which was obviously just a case that we had invented, but the reality of what was to come. That is how we prepared. So again, it was all these things that you mentioned in the beginning that happened to us, like with Sandy, et cetera, which give us actually the ability as an organization to always try to think ahead of the what if. Are we prepared? And ask that question. And literally on January 8th, we had asked that question related, unbelievably. We think back to it, it's like, oh my God, this is unbelievable. But we were preparing for the possibility of a deadly virus outbreak. That's how our story began with the pandemic.
And what would you say as you look at it? Because we've all done, as we do with all tabletops, we always kind of look retrospectively and kind of analyze, did we do the right things? What could we have done better? What's been your read so far on that? What were the aha moments that you had, particularly in the first few months of the pandemic when, New York was really getting devastated?
Sure. That's a great question, Rod. And looking back, I think we didn't anticipate the speed at which things would change. It was that wave, and how just there were days in which a number of patients that were coming in was just so incredible. And we had to match that. What I mean by that is that the reality is that when we first started, before we got our first patient, we anticipated what this might be based on what was going on the West Coast, and we allocated half a unit, and it was essentially like just a few beds. And then we said, well, maybe we'll do an entire floor, like we prepared the single bedded rooms, etc. So those were about 34 beds that we would say that we might extend fully to that, and those were acute beds. And then there was also a few beds in the ICU. But the reality is that once things actually began at the height of the pandemic, every single floor had to be converted. And so we had to keep up. And how quickly were we able to get ready? So with all the things that getting the rooms ready, getting nursing, getting staff, all these different things, workflows. And that, I think, is looking back, was probably one of the most important lessons that we learned. Can we very, very quickly get things up to speed? Or how quickly can we get up to speed? And I have to share with you, I'm very proud of my team for getting to a point in which there was a point at which we needed to convert, to stand up at about 20 additional beds. And we converted a PACU, part of a PACU, within 4 hours. We were able to stand up, which was incredible. Again, just thinking about the monitors, the beds, everything that you could possibly need to take care of COVID patients. So that part actually I think was important, and we still use that to this day, thinking about how quickly can we get up to speed if we needed to.
Because as a chief medical officer, you're really kind of the air traffic controller for a lot of things. There were supplies and people and space. And I remember back then, that, there was a point on the supply side, we were really struggling with even the most mundane things like masks and gloves, where we're going to have enough. And as the air traffic controller, how did you kind of deal with all of those different issues hitting you all at once?
So you're absolutely correct, and we were fortunate that first of all, the communication with the key individuals in those areas. So the supply chain team, in terms of thinking about what do we have, what does it look, what does the outlook, what does it look like in terms of how many day supplies do we have, etc. And then partnering with infection prevention and control in terms of how we were going to use various supplies. What do we need to do? Like in terms of the types of masks that would be used in certain scenarios, in N95s versus surgical masks versus things, the gowns, etc. So all of that had to be plotted relative to what was coming in, and then understanding the rate at which we were using the supplies, so that we were not getting into a situation where our folks actually were running out. Fortunately, we were able to put these two things together, meaning our supplies as well as our policies, in order to effectively keep people safe and make sure that they had what they need. We also manage effectively, like in terms of the as you mentioned, actually, like the spaces, like the teams, like could we expand and contract as needed? Now, I wish I could tell you that at the height we were contracting, but we weren't. I mean, the reality is that we had to keep expanding because, again, all the floors actually were were very, very busy. And then, as you mentioned, there was also the people factor and the teams, and just constantly just assessing and reassessing the fatigue factor. The fact that there were so many patients who were there, both on the acute and ICU side, how were we supporting them? How are we supporting the nurses, the physicians, et cetera? And of course, as everybody experienced as well, there was the families and the fact that they couldn't be at the bedside. So there were layers here to this and we had to think outside the box in terms of how to address these issues in terms of communication. And the reason I mentioned that piece through the families and communication is because that was an additional aspect that the teams actually had to deal with, because they're taking care of the patients, but also taking care of the families in a way, because the families couldn't be at the bedside.
So now, 18 months later, how are you continuing to build the resiliency of the staff and the mental health issues of what we're dealing with?
Yeah, the truth is, Rod, it's been a long 18 months plus that we've dealt with the pandemic, and yes, our people are tired. There is this aspect of fatigue, having dealt with this. But on the other side, they've been able to see the changes. They've been able to see the fruits of their labor, and we celebrate what I call the wins. And there have been even when we reach certain milestones of X amount of patients that were successfully discharged from the hospital, and making sure that people know that. Or there was a particularly difficult situation for a patient, let's say in the ICU, where perhaps it looked as if the patient wouldn't survive, but lo and behold, everybody actually really pulled through. They came together, complicated, and they were able to successfully discharge us. Or even a single letter from a grateful patient communicating to the staff about their experience, what happened, and what this means to them. That goes a long way to lift the spirit of the staff, because they know that this is now putting that face and the family to something that they had a part in, making a difference in one person's life. Then there's also moving to what I call the new normal. I'm not going to say going back to it, but it's the new normal. So what I mean by that is that we went at the height of the pandemic where all the floors are converted. It was all COVID all the time, like, ICUs, acute, etc. Where now, today, like, fortunately with the vaccine and with the way that things are, the vast majority of the patients being cared for are not COVID patients. So that we are able to provide care to a whole host of patients who are coming in for non-COVID reasons, meaning stroke patients, heart failure patients, the OB patient, pediatrics, and all that. So the hospital is really able to function in that sense and deliver quality care on those floors down to those patients. But yes, there is a smaller subset that are coming in unvaccinated with COVID, and we still have designated areas where we can care for those patients as well. And so the staff know and they can share those stories with the staff because they see that they have that wave actually has come down. We are able to take care of the patients that they would normally care for. But yes, there are still patients that some patients that are very, very sick with COVID. It isn't the way that it was last year, knock on wood, but this is where we are. And so we are also, the other important thing that I will share with you in terms of them thinking about how do we support the staff is that we communicate a lot with them in terms of what's going on, what's going to happen, where are we with the vaccines, like what do we anticipate. And the other important thing in terms of the outlook is also to put it in perspective of what's happening in the rest of the country. I mean, they read the news, etc. So that type of dialogue actually is important with our staff. And then one other very, very important thing that we have done, which is we've always had resources for our staff in terms of mental health, but we've expanded that and made sure that they know that how they can access it, and also provided a variety of other resources for wellness. And the types of programs that we've done are things that sometimes we've gotten feedback from the staff that are important to them. Case in point, where we have a segment or program related to healthy eating and healthy cooking. And it might sound like a simple thing, but these are the types of things that are important to the staff, and they want to see that their ideas are being implemented in this way. So programmatically, we have been able to put together a portfolio of these types of support for our staff, knowing full well that, as I said, they are fatigued. It's been a very, very long 18
Well, I think overall, New York has done an amazing job in terms of really getting this under control. I think it's a real case study in where you started from and where you are today.
Yeah.
The other thing that I'd love to ask you about, because you've had so much experience in all of these areas, that we wish it was just COVID, but 2020 was also a year that we really put the bright light on healthcare inequities.
Yeah.
And how did you deal? Because what else is there for the CFO to deal with? But all of a sudden, the bright light was there, and it said, "Wait a minute, things aren't what they should be," and it got clear. So, on top of everything else, they probably ask you to say, "Okay, Fritz, what are we going to do with this?" Right?
It's a great question, and here's the interesting thing. It just so happened that sometimes you have experiences in your life, and it seems as if those roads actually converge. And I used to be the associate dean for diversity and academic affairs at the school, and the reason that I wanted to do that work is because I do have a passion in addressing healthcare disparities, and also making sure that the care that is being delivered is as equitable as possible. And when I became the chief medical officer, it was something that, again, I was very, very, not only very passionate about, that I always wanted to make sure that we don't have two different standards at all. And I'm very proud to say that at NYU, that is not the case. It's the same playbook, regardless of who the individual is, regarding insurance level, etc. This is what we do. And so what the pandemic did is created an opportunity to do a stress test. What was going on. And as you and I know, there's a lot of, we know that there were some, there are populations and there are groups of individuals, including the Black and Brown communities, that were disproportionately impacted by COVID, which is absolutely true. Individuals actually were getting, were getting infected with COVID, and they were presenting actually to the hospital. So the question that I asked, now very important to answer, is the care being delivered to these patients any different? And what is the difference in outcomes?
Yeah.
And we looked at that. And lo and behold, what we found is that at NYU, that the outcomes were not different. And so, to be very specific, and in fact, we published a paper on this because we showed that the outcomes for Black patients, Black patients who presented to the hospital did not have an increased risk of either ending up in the ICU or dying. The important thing to note about that paper and what it uncovered is that, yes, putting together a structure in the hospital, having the same playbook, that's effective in making sure that outcomes are equitable. However, the individuals who are coming in with COVID were more likely from Black and Brown communities, suggesting that there are issues that need to be dealt with outside
Community level.
the hospitals in the communities. So what does that mean for us? So what it also did for us actually is that it allowed that it was a perfect opportunity for us to do something which we had intended to do anyway. But we launched an Institute of Excellence in Health Equity. And the idea behind that institute was to look at our mission areas and say, okay, we're going to think about equity from the perspective of not only education, from the perspective of research, but also from the perspective of clinical care delivery. And we now have done that. And we are actually doing this now in such a way where every single department has an equity goal and has tools that they're using and that we're partnering with them to ask the fundamental questions about how can we do better. So to give you a concrete example, we would look at in OB, they might look at C-section rates and ask the question about how they're doing in that front with different various populations. We looked at cardiology. We look at what we're doing actually with not only heart failure, but patients presenting with noise elevation MIs, etc. So there's a lot of opportunities to actually look at these things systematically and also think about the community engagement piece. So while I'm saying to you that the Institute actually is also looking at the playbook, looking at the system, etc., we recognize that it is also important to be engaged with the community. That became exceedingly clear once the vaccines became available and we were dealing with vaccine hesitancy in certain populations. How do you engage with individuals and what are the methods that are effective to address vaccine hesitancy in at-risk populations? So that's where we are in it. And of course, we continue that work. But I do believe that it has been an important step for us in terms of who we are as an organization and our commitment to communities and to patient care.
Fantastic. Just fantastic. I think you've kind of summarized, kind of all the different parts of it, that we face with besides just what happens within the four walls, but then what extends beyond that. I mean, you've really done it. Last question, I just got to ask you, and, with all of the suffering that's going on this year, so many things haven't gotten the kind of attention they should. And back in Haiti, Haiti's had to go through yet another earthquake in the middle of a pandemic. Anything that you can tell us from how things are going there? And I know you've had experience being there before when they were in need.
Sure. Thank you so much for asking. It means a lot to me. And of course, as you said in the introduction, I'm from there. I was actually I was born there. Believe it or not, I went to school there. And before I had the opportunity to continue my training here in the United States. And during the earthquake, last earthquake, it was I had the opportunity to lead a team, a response team. And I was in L'Hôpital Général, which is one of the biggest public hospital in the country, and helped to really get things, provide support actually for desperately needed patients who were impacted by the quake. One of the things that is important to note is that the country never really fully recovered from that earthquake. So this was additive, unfortunately. Yeah. And of course, given the political climate, it meant that it was a perfect storm in many ways, because the infrastructure and the healthcare infrastructure is practically non-existent. Much of it actually is dependent on non-governmental organizations that are there actually to provide support. And so what we've been doing, that we actually specifically, is that there are organizations that are based in the United States, my partner, is to provide support. And when this particular last quake actually hit, we immediately mobilized to get needed supplies on the ground. And there are also individuals who were teams actually that were going to Haiti to provide support and to do what they can. And so there's the immediate response, which is something that we've been working on, which is very, very important. And then it's important to think about then what happens next. And I wish I could tell you that that plan is crystal clear and that that here it is, this is what we're going to do. But no, unfortunately, there's still a lot of uncertainty. There's still a lot of instability from a political perspective, and unfortunately, there's the situation is such that there are gangs and crime that's going on that makes it actually a very dangerous type of situation. So, from a humanitarian perspective, there's much to be done in the country, and responding actually immediately, like in an immediate period of a crisis, such as an earthquake, is one thing. But then it's really more about what happens next. Can we create a stable environment in which we can ensure that health care is being delivered in a manner that will support the population, etc. So there's more to come on that. I mean, it's something that we continue to work on a lot and continue to have extensive conversations, and we're rolling up our sleeves to do it. But quite frankly, it's going to be an uphill climb. I will share with you a book that you're very familiar with that is about Dr. Paul Farmer, that is called Mountains Beyond Mountains. And it is about the fact this saying, actually, in this Creole saying, that if I say it in Creole, it's Deyem one, Gem one, which means that beyond the first mountain, there are other mountains. And it speaks a lot to the history of the country, where just after you think you've gotten over that particular hill, and yet there's another hill. That is unfortunately where we are now, given this most recent earthquake. We have another hill to climb.
Yeah, that's a beautiful way to end this, because it's a metaphor that I think is apt for us all, right? Particularly in healthcare. And, Paul Farmer's story in Haiti, and, really putting a bright light on the country in terms of what's needed. But, I just need to say we could go on for another hour here. It's wonderful to have folks like yourself serving. And it's great to be able to highlight what you've been able to do, how you've been able to do it, and just how proud NYU Langone should be of their chief medical officer and others. So great to have you with us today. And thank you so much for this, conversation.
My pleasure. Take care.